Hello, friends. So today I'll be talking a bit on aortic stenosis, what an intensivist must know. I thought I'd do a few series as in certain conditions where not necessarily it may be our specialty, but what an intensivist should know. So I wish to acknowledge Dr. Sohini Roy who helped me develop this content. So aortic stenosis, as you know, friends, it's a fairly common sort of a condition that we encounter in ICU. For an intensivist, what is the knowledge that one needs to be aware when you are dealing with this patient? So we'll just look into the pathophysiology, clinical features, and what are the therapeutic modalities in a brief sort of a format. So this is the sort of anatomy of a normal aortic valve, which is a sort of it has three leaflets. So it is a tricuspid sort of a valve. So in aortic stenosis, as you see, there is a narrowing of this orifice that tends to happen. So there are quite a few etiological factors, which I'm sure most intensivists would have read from their MBBS time. So the commoner ones are congenital aortic stenosis. So this is an aorta, and in congenital, you could have a supravalvular and a subvalvular aortic stenosis, and this tends to occur more in younger individuals. So the ones which possible as an intensivist we commonly encounter is a degenerative sort of aortic stenosis that tends to occur in elderly individuals due to calcification and fibrosis that tends to happen as a degenerative process in aortic stenosis. And one another common variant possibly we used to see earlier more often and in our tropical countries is the rheumatic heart disease and the bicuspid aortic valve causing degeneration. So when there is a bicuspid aortic valve, they tend to have more degeneration and becomes a commoner cause of aortic stenosis. And rheumatic heart disease is something that tends to happen in our countries and not to be undermined. So these are some of the common. So the causes are not many. So mainly the degenerative and rheumatic heart disease is something we commonly see. And but if someone has a bicuspid aortic valve, that tends to lead to aortic stenosis. So these are some of the common etiological factors. So when we deal with aortic stenosis in ICU, there are markers which tell you that patient has severe aortic stenosis. So there were these traditional conventional markers. Now they have certain novel markers. The traditional markers of severe aortic stenosis is where you have peak jet velocity. So because the aortic aortic valve is stenotic, the blood flows at a much higher velocity. So the peak jet velocity is more than 4 meters per second. It can be looked at as severe aortic stenosis, or when there is an area of the aortic valve is less than 1 centimeter square, you call it as severe aortic stenosis. And mean pressure gradient, if it is more than 40 millimeter mercury, we call it as severe aortic stenosis. So I'll explain to you as to what all these entities is, and maybe I'll do a separate video only talking about the echo evaluation of aortic stenosis. So this video I'll be just talking on the overview of aortic stenosis. And if LB ejection fraction generally is sort of a overestimated in aortic stenosis, and in this situation, if you have LB which is less than 50%, this confers severe aortic. So peak velocity more than 4 millimeter per second, and the valve area less than 1 centimeter square, and mean pressure gradient more than 40, and ejection fraction less than 50, all are the traditional markers of severe AS. So there are certain novel markers. Novel markers is because LV is hypertrophied and LV is working hard to eject the blood into the aorta. So there is a backflow which causes aorta, the left atrial enlargement. So if the atrial size is more than 12.2 centimeter, these are the newer novel markers. Or if there is increase in the mean pressure gradient following the patient exercises and there is an increase in the mean pressure gradient to more than 20 millimeter mercury, we call it as severe AS. This is a newer marker. If the left ventricular hypertrophy is more than 15 millimeter, we call it as severe AS. Or if there is global left ventricular longitudinal strain less than 15.9%, and if BNP, beta natriuretic peptide, is more than 130 picograms per ml, we call it as severe AS. So these are some of the newer novel markers. Maybe trainees can keep this in mind. So traditional markers is easy to remember. The newer markers, just remember BNP and LVH more than 15 millimeter, and mean pressure gradient more than 20 millimeter following exercise, and LA is enlarged as a pathophysiological process. So this is pictorially, you can sort of tend to remember this. So I'll just show you in a very schematic way, just for all the trainees. I told all my trainees when a pathophysiology of this has to be understood, it's good to understand in a little pictorial format. So when you look, this is just a schematic representation of LV, LA, and the aorta. And as you see, this aortic valve is stenotic. So because there is stenosis, the LV has to increase its efforts or increase its pressure. So there is an increase in the intraventricular pressure to eject the blood into the aorta. And because LV is working hard to eject the blood into the aorta, so the LV tends to get hypertrophied. So this is the hypertrophy that tends to set in. And because LV is working hard and it is hypertrophied, the passive filling of the LV from the left atrium tends to get impaired. And left atria has to work hard to push the blood into the LV. And because of the increased sort of a contraction of the LA to push the blood, so the LA tends to get hypertrophied. So LA has to work hard to push the blood into the hypertrophied LV. Because of all these, because of the hypertrophy, there is reduction in the left ventricular compliance. And because it is hypertrophied and LA is working hard to push the blood into the LV, there's increase in the left ventricular end diastolic pressure because it has to increase its pressure to eject the blood into the aorta. And because of all these, there is increase in the wall stress and there is myocardial ischemia that tends to set in. So please remember, all the trainees, I'm sure you are aware, the coronaries tend to get compressed because of the hypertrophied myocardium, and the coronary perfusion pressure and the coronary blood flow is impaired. So that's why there is subendocardial ischemia that is innately present in aortic stenosis, and they are more prone for ischemic symptoms, which I'll talk in clinical features. All these pathophysiological process leads to angina, syncope, and shortness of breath, and they can cause arrhythmias, tachyarrhythmias of atrial fibrillation with fast ventricular rate tends to worsen this whole conundrum of pathophysiological derangements that tends to happen in aortic stenosis. So this increase in the wall stress is determined by the Laplace law, which is left ventricular pressure into left ventricular radius divided by left ventricular wall thickness. So this sort of determines the wall stress that tends to happen in aortic stenosis. So that's about the pathophysiologicals. For all the trainees, just remember this picture, very simplified, schematic. Even in exams, if suppose this question is asked, just put this figure. So that gives you a bit of a clarity as to what really happens. So LV is working hard, increased left ventricular pressure to eject the blood, increased left ventricular end-diastolic pressure in the setting of LVH, which leads to reduction in the compliance and subendocardial ischemia that tends to happen, and increase in the wall stress. And LA is working hard to push the blood into the LV, which leads to LA enlargement. If you can sort of remember this in a pictorial way, I think your ability to recall also will be much better. So what are the criteria for aortic stenosis in patients with normal LV function? So there are 4 variants that we look into to determine the severity of aortic stenosis. There is, like in any other situations, there is mild, moderate, severe, and critical. So mild aortic stenosis is where your valve area is more than 1.5 centimeters square. Mean pressure gradient is less than 20. It should be less than 20. If it is more than 40, you call it as severe. 20 to 30 is moderate. And the velocity should be 2.6 to 2.9 meter per second. And indexed valve area, which is centimeter squared divided by meter squared, should be more than 0.85. So moderate aortic stenosis, once you have these 4 sort of a domains that we need to look at, it is simple for you to remember this. So moderate aortic stenosis, valve area is 1 to 1.5, mean pressure gradient is 20 to 40, velocity is 3 to 4, and indexed valve area is 0.6 to 0.85. So if it is severe aortic stenosis, which we had a recently patient severe aortic stenosis with multi-organ dysfunction, I'll show you the echo. So where valve area was less than 1, mean pressure gradient, our patient with severe aortic stenosis, which is currently in my ICU, has had a mean pressure gradient of 70 millimeter mercury. And this patient had a velocity of more than 4, which was 4.5 or 4.6 meter per second. And the index valve area also was less than 0.6. And we call it as critical aortic stenosis if valve area is less than 0.5 centimeters square. So this is the criteria. Even in exams, they ask, so put it in a tabular format so that there is some clarity in your conceptual understanding. So again, just to show you the pathophysiological sort of changes that tends to happen and why this happens. So this is a normal patient, in the normal patient, your LV pressure has to increase and it has to equal to the aortic pressure for this aortic valve to open. So the aortic valve opens when the LV pressure builds up with LV filling to the point where it equalizes the pressure of aorta. That is when your aortic valve opens. So which means there is no gradient between when the aortic valve opens, there's no gradient between the aorta and the LV. And there is a easy ejection of blood into the aorta. But so this is a patient with aortic stenosis, where aortic stenosis, LV has to increase its pressure to supranormal levels. And this increase in the pressure should be more than the aortic pressure to eject the blood into the aorta. And this leads to something called transvalvular gradient, which is aortic pressure with LV pressure. So this is what tends to happen in aortic stenosis. So for all the trainees, remember this pictorially so that you can recall as to what. So there is supranormal increase in the LV pressure, which exceeds the pressure of the aorta to eject the blood into the stenotic aorta, leading to transvalvular gradient, which is equal to aortic pressure with LV pressure. And again, schematically to show, because there is this brown thing is a LV hypertrophy. Because LV is hypertrophied, the diastolic filling, because it's hypertrophied, there's not much space for the filling to happen. Diastolic filling is impaired. There's increase in the diastolic pressure, and LV becomes very preload dependent, and it needs high filling pressure. Because there is diastolic dysfunction, there is a high filling pressure, and this can lead to secondary mitral regurgitation because there's not enough space to accommodate the blood, and there are high filling pressure and becomes preload dependent. Secondary MR sets in severe aortic. So the patient we had a severe aortic stenosis with a mean pressure gradient of 70 and jet velocity more than 4.6 and had a secondary MR. So please understand. So you need to keep this in mind when you're dealing a patient in ICU with severe, because ICU patients who tend to have moderate to severe AS. And it is important to understand its hemodynamic sort of a ramifications that patient can have. And because there is secondary MR, there is increase in the left atrial occlusive pressure or filling pressure or pulmonary capillary wedge pressure increases as well. Because there is a constant increase, LA is enlarged, back pressure happens, so pulmonary artery hypertension sets in, RV dilatation happens, and the RV dysfunction. This is the typical conundrum of severe aortic stenosis. Because your LV is hypertrophied, there is secondary MR, LA pressure increases, LA is enlarged, and that leads to pulmonary artery hypertension. Chronic pulmonary hypertension leads to right heart dilatation and RV dysfunction. This is the typical sinister conundrum that tends to happen in severe AS. And this is a recent patient we had with all this conundrum. And we thought it's good to have a clarity amongst intensivists as to how we have a conceptual understanding of this aortic stenosis. So the clinical features, so we'll just talk about the typical clinical features, which I'm sure you may have been studying since MBBS time, is they'll have angina because there is a chronic sort of a ischemia that tends to happen due to subendocardial coronary perfusion is impaired. So they have angina, they have exercise intolerance, and they lead to syncope. I'll talk to you as to why physiologically this tends to happen. We'll explain. And then they have SOB. So the shortness of breath is a late manifestation of aortic stenosis. So why does angina happen? So already I had explained to you, angina happens because there is this is just a simplified representation of LV and LA. There is LV hypertrophy. Because there is hypertrophy, there is compression of the coronary perfusion vessels. So the coronary vessels tend to be compressed, and the coronary blood flow gets impaired, and there is increase in the left ventricular end diastolic pressure, which we all spoke about. So the coronary blood flow is limited because of the hypertrophy and subendocardial ischemia, and the coronary perfusion pressure gets impaired, and this leads to there is some sort of a chronic ischemia which leads to some sort of an angina for these patients. And why does this syncope and exercise intolerance happen? So conceptually understand, when you are exercising, your systemic vascular resistance comes down. And afterload, because there is reduced systemic vascular resistance following exercise, there is reduction in the afterload. And this reduction in the afterload leads to increase in the cardiac. So this happens in a normal individual as a physiological response. Your SVR comes down, afterload comes down, there is improvement in the cardiac output to compensate for the effort that you are putting in. And this process does not happen because your SVR comes down, your afterload, but cardiac output cannot, there is a fixed obstruction. Your cardiac output is not able to compensate for the sort of a reduced afterload that tends to happen in effort tolerance. And this leads to, because there is no compensatory increase in the cardiac output, patient tends to have syncope. And our severe AS patients came with a syncope with hypoxic ischemic encephalopathy in the setting of severe AS. And the shortness of breath is the late manifestations of aortic stenosis. And this happens due to, initially, there is increased diastolic blood pressure, diastolic filling pressure, increased LV end diastolic pressure leads to increased filling pressure. So there is a diastolic dysfunction. Later on, it leads to systolic dysfunction, systolic heart failure, and then which later on leads to pulmonary artery hypertension and the right heart failure. So this is the typical conundrum. So I'm trying to explain to you physiologically as to why these symptoms happen in severe aortic stenosis. And there are non-cardiac sort of symptoms like GI bleed tends to happen more commonly in aortic stenosis because of the angiodysplasia that tends to happen because of these pressure changes, and they can have embolic strokes. So these are some of the non-cardiac clinical features. And our patient, we did an MRI, he didn't have any stroke, but these are something that you can expect in severe AS. So this is just to show you a video. So as I said, I will take a separate lecture on the echo features of aortic stenosis. So this is a patient in our ICU currently where we did the echo, and I'll just show you all the echo features that tends to get manifested. Okay, so this is, as you see here, the ejection fraction. So this is a severe AS where your LV dysfunction has set in. As you see, the ejection fraction is 43% or 40%. So this patient is severe AS with LV dysfunction and had gone into some sort of an RV dysfunction also. And I'll show you, it's a very simple echo evaluation of aortic stenosis. Take an apical view, 5-chamber view, place your Doppler in the LVOT, and get a Doppler measurement, and that will give you the mean pressure gradient. I'll show you that, what we did in these patients. Okay, so this is the apical view. You just take a 5-chamber view. So the patient had a MR jet, as you see in this. So we'll just look into the aortic valve. So this is a 5-chamber view. So LVOT is opened, as you see. So you are seeing the aortic stenosis. So this is, so just look at this. So you've just placed LVOT, you took an LVOT, you placed the pulse wave Doppler, and you took a Doppler measurement. And if you see here, the pressure gradient is 74, and peak velocity, as you see, is 431 centimeters, which is, so which is a severe AS, which I said more than 4 meters per second is severe AS, and mean pressure gradient more than 40 is severe. So this patient, as you see here, it showed 74.3 millimeter mercury. So this is a simple echo evaluation. Very simple. Every intensivist can do this and capture the severity of aortic stenosis. So I'll take a separate video on the nuance of aortic stenosis echo evaluation. And this is the RV pressure. As you see, the is 35.8. So around 45 was the PA pressure this patient had. So that's about so we spoke about the etiology of aortic stenosis. Most important in aortic is understanding the pathophysiological, and that will sort of unfold as to why certain clinical features tend to happen, and echo evaluation. So investigations, you can do ECG, it shows sort of an LVH pattern, and then you can do an X-ray which shows an aortic enlargement and the aortic sort of a border. I'll show all that in maybe next video. So the broad principles of management for intensivist is what you need to understand when you have a patient with aortic. So most important is you have to maintain good diastolic blood pressure, because you need to have diastolic blood pressure is what determines the coronary perfusion. So your coronary perfusion, CPP is the coronary perfusion pressure, is aortic diastolic blood pressure minus left ventricular end diastolic blood pressure, left ventricular end diastolic pressure. So in severe AS, your diastolic blood pressure tends to be low, and left ventricular end diastolic pressure remains high. And both these together is a sinister combination, which reduces your coronary perfusion pressure. So this is the pathophysical process. That's why it is important to maintain good diastolic blood pressure, to maintain good coronary perfusion pressure and coronary blood flow, and prevent ischemia. And another important aspect of severe AS is optimize preload, and one should not use nitrates or NTG, because in ICU, when they come, we have a predilection to use more of nitrates. So one should not use nitrates or veno because they're preload dependent, and be very vigilant and cautious whilst you're using diuretics. So you have to be very cautious in reducing the preload by using nitrates and furosemide, and they should try your best to try and avoid and maintain euvolemic status, which every intensivist is so good in assessing the volume status, and avoid tachycardia. So you can use beta blockers, you can use ivabradine, so on and so forth. And tachycardia is not good, as we understand, for your coronary perfusion and your diastolic sort of a flow filling. And patient has a contractility issue, severe AS with LV dysfunction, supporting myocardial contractility may be needed. So you may have to, so in our patient, we did use dobutamine, but you have to be very careful because it's a fixed obstruction. It should not, your use of inotrope should not increase the heart rate. So you can use a low dose inotrope. So we use low dose dobutamine up to 10 micrograms. It did not increase that, and you control the heart rate. So if myocardial dysfunction is present, you may have to use certain drugs to improve the contractility. Most important, treat the reversible causes. Like our patient had a AF with fast ventricular, so we had to correct it very aggressively. And if there is an underlying sepsis or a bacterial infection, one has to treat, and one has to treat any other hypovolemia due to GI bleed, so on and so forth. So treating reversible causes also is terribly important to improve the outcome and optimizing hemodynamic status in patients with severe AS. And it is it is sort of emphasized that intubation or jumping and intubating this patient as much as possible to be avoided because of a lot of heart-lung interactions that tend to happen. So these are some of the broad principles. Even in exams, I think just remember all these different dimensions which are so important in ICU when you're dealing with aortic stenosis to manage this. And temporizing measures is, you can think of balloon aortic valvuloplasty to relieve because the definitive treatment is to relieve the obstruction. So aortic valvuloplasty is something that one could think of. Even intra-aortic balloon pump could be considered, because balloon pump helps to reduce afterload, increases the coronary perfusion pressure, which is a problem in aortic stenosis, and increases the diastolic blood pressure, which is also a problem in aortic stenosis, and which is so much important to improve the coronary perfusion pressure. In extreme cases, all our intensivists are now becoming experts in VA ECMO. So VA ECMO could be considered as a bridge for doing a definitive procedure, which is surgical aortic valve replacement, or now you have a transcatheter aortic valve replacement or aortic valve implementation. So definitive treatment remains surgical aortic valve replacements or transcatheter aortic valve implant or replacement. So despite all this, 30-day mortality in patients with severe aortic stenosis plus shock, which we have at this point of time, is 33.3%, and our patient has multi-organ dysfunction, so we are optimizing this and with an intent to do TAVI for our patient. So the mortality remains at 33.3%. So that's about the broad principles. So I spoke about the common causes of aortic stenosis. Most important in this talk is to focus on the pathophysiological understanding as to what an intensivist should know, because all those pathophysiological changes explains your clinical features and has a bearing on your treatment sort of the modalities that you put in place in ICU. So thank you, friends. So I request you all to submit your valuable work to Journal of Acute Care, which comes out every 3 to 4 months. Of course, you can visit my website, www.drpradeeprangappa.com, to rehear to this lecture. So thank you one and all.